going to be looking at the issue of suicidality in early adulthood. As you can see by this picture from the CDC website, suicide was the second leading cause of death in those aged 25 through 34 in 2020. And the rates have been increasing in this age group. 20% of college students reported suicidal thoughts, 7% reported suicidal attempts. So you can see that this is an issue that greatly affects college students as well. In fact, when you look at the rates of suicidality and suicide completion, it's consistently highest among white males ages 25 through 34 of all age groups and all races and ethnicities. So this shows that this definitely is an issue affecting young adults. In fact, the data shows that young adults are at the highest risk for completing suicide, which means it is something that as mental health workers, we need to be aware of, and we need to be able to properly assess and treat in our counseling sessions. So what puts this population at greater risk for dying by suicide? Well, first of all, the risk for dying by suicide is based on a greater accumulation to stress or risk factors. There's things such as adverse childhood experiences, stress in life, mental disabilities, other things like that that just get compounded and add up, lead to greater risk. Strongest factors for this age group are current mental disorders and a history of suicidal behavior and or psychiatric care. There's also a theory called the interpersonal psychological theory of suicide, which states that suicide risk is a result of a person who feels like they don't belong or they have thwarted belongingness, isolation, loneliness. They also feel like they're a burden. They're better off dead. They're a burden to other people, plus they have the capability to actually carry it out. And when you add all of this up and you think about the stress of life adjustments that this age group is going through, you can see why they'd be at harder risk. And then you add in the COVID pandemic, which really helped to facilitate social isolation, so that thwarted belongingness. And it just kind of really came at a time of life for today's emerging adults that would really add to accumulation of stress and put them at a greater risk of suicidality. Finding a good assessment for suicidality is tricky. Assessing suicide is tricky because not everybody who thinks about dying by suicide actually carries it out. Not everybody who has suicidation turns it into a plan that is completed. And while there are over 20 different tools that have been designed to meet this need, Andreotti et al. Looked at those tools and said many of them fall short. So it is tricky to be able to truly assess suicide. So we're going to look at a few different tools and then tell you the one that we decided on. The first assessment we're going to look at is the Suicide Ideation Attributes Scale. This scale was developed in Australia. It's a web-based measure. You can find it online. It's quick to take. It's only 5 questions, and it's a 10-point scale where you, as you can see by this picture here, where you rate where you fall and to the presence and the severity of suicidal thoughts. It does have high internal validity. There's internal consistency, which matches other similar assessments. It's easy to give out, easy to score, and to see if there's possibly a risk with a person that comes in. You can do it very briefly, very quickly, but future research is needed on this scale to see if it is something that is truly reliable and valid, and that will work well as an assessment. So that is not the one that we used for our project. A second scale to look at suicide ideation is the Beck scale for suicide ideation. This one is actually considered one of the main standards for looking at suicide ideation, this one along with the Columbia. It has 21 items and it measures the severity of suicidal wishes and plans. So how severe is their ideation and what kind of plans do they have, if any, how much have they thought about carrying out that plan, how much have they done to carry it out. It's used for adolescents or adults as an indicator of suicidal risk. It was developed originally in the 1970s, and it was developed to be used with psychiatric patients. In fact, the manual itself says that caution should be taken when used with other populations. So it's not necessarily something that translates well to just your regular person who comes into a clinic for counseling. So it's not necessarily something that can be used as a standard, even though it has been used as a standard. So that is one of the reasons that we did not choose the Beck scale for suicide ideation as our assessment for this project. Now we come to the reasons for living inventory, which is really a neat inventory. What they did in this assessment is that they looked at people who have risk factors and they said, these people have all these risk factors, but not everybody who has risk factors actually goes through with suicide. So what makes the difference? And they came up with an idea that maybe there's some reasons for living, some assets a person has in their life that would keep them from carrying suicide out. So this has 32 items that assesses the reasons a person has to not die by suicide. It looks at things like relationships, beliefs, future goals, things like that. And it's specifically targeted to young adults ages 17 through 30. So it's a newer assessment. There's also the RFL-YA2, which adds a spiritual component to it as well. But this one doesn't have a lot of research into the use of the assessment. So even though it's a great idea and a great assessment, there's not a lot of empirical research to back it up. Now we come to the Columbia Suicide Severity Rating Scale, the CSSRS. And this is one that has often been used as the gold standard for suicide assessments. In fact, as we were doing this project, 2 of us used this at our practicum site. It has 18 items. It was initially developed for use with adolescents. It is not self-administered. You have to have a counselor or somebody there asking the questions and doing it with them. And like I said, it's often considered the gold standard of suicide assessments. However, studies have shown that there are gaps in the classification system of this assessment and also problems with the classification, and that it's also missed people who later went on to die by suicide or shown false positives. So there's some question about should it be the gold standard. Giddens et al. Did a study and they said that there's really more problems with the Columbia than there should be, and that perhaps it's time for a newer assessment to take its place, a different gold standard. For these reasons, we did not choose the Columbia for this project. So what assessment did we use? I'm so glad you asked. We used the Suicide Status Form, or SSF. We really like this one because it is a clinical assessment and a treatment planning tool. It's actually part of a bigger intervention that can be used, which is called the Collaboratory Assessment and Management of Suicidality, or the CAMS intervention. It is a 6 5-point rating scale. They look at things such as psychological pain, stress, agitation, hopelessness, self-hate, and overall risk of suicide. It has both quantitative and qualitative measures on it. It has things that the client can answer themselves, as well as something that's meant for a deeper discussion. And it's been shown to be valid and reliable, and also to aid in improvement when used as part of the CAMS program. We really like the SSF and the CAMS program because it gives a treatment, it gives an intervention, and it felt a little bit more personal. You're having a conversation with the client, you're going through these things, you're looking at things from their perspective a little bit more, and you're able to really start that conversation into it. And when you use it as part of the CAMS program, you're using it more than one time to assess and to see if there has been any improvement throughout. And as I said, studies have shown that it can lead to improvement in suicide ideation and suicide completion. So the rest of our project, we're going to take a closer look at the Suicide Status Form and the CAMS program.
While there are many studies involving the SSF2, one of the more foundational ones was conducted by Conrad et al. In 2009. They did a study at the Mayo Clinic in Rochester, Minnesota, where they had nurses and psychiatrists flagging inpatients who would qualify for the study. They identified 149 adult psychiatric inpatients. 108 of them presented with suicidal ideation or behavior within the past 48 hours of admission. 41 of them were the control, and they had no suicidal ideation or behavior identified in the prior 48 hours to admission. The study did exclude prisoners, any patients who presented with psychosis, or any who were unable to complete the paper assessments due to cognitive limitations. There were 45 men and 100 women included in this study. The cultural breakdown was 90% Caucasian, 5% Latino, 2% American Indian, 2% African American, and 1% Asian. This study utilized Spearman correlations for its factor analysis. It showed none of the inter-item correlations were high. In other words, each of the factors measured exactly what it was supposed to, and they were not redundant across the factors. Communality estimates for each of the 5 core ratings are pain, which was 0.63, stress, which was 0.71, agitation, which was 0.8, hopelessness, 0.76, and self-hate, which was 0.72. This shows that the model works well for each of these rating variables and measures them uniquely. It also showed canonical correlation between chronic non-resolvers, which are individuals who are chronically suicidal, and the acute resolvers, which were individuals who are acutely suicidal. It was a 0.4 correlation, which indicates that the SSF2 can reliably categorize the 2 different types of suicidal patients. 9 other assessments were administered to the patients in this study. These assessments showed convergent validity with the SSF2 when calculated through the Spearman correlation. Each was found to be significant for the factors when compared. The other assessments include the Behavioral Health Questionnaire 20, Outcome Questionnaire 45, Orhoch and McCulser Mental Pain Scale, Pressure Inventory 3, Straight Trait Inventory for Cognitive and Somatic Anxiety, Barat Impulsiveness Scale 11, Beck Hopelessness Scale, Beck Self-Concept Test, and the Reasons for Living Inventory. Reliability was established through test-retest reliability as it was administered 3 times to patients. It showed a statistically significant correlation for each of the factors of the SSF3. Internal consistency was also addressed using a Kornbach alpha correlation with each of the additional assessments. The Kornbach alpha ranged from 0.78 to 0.98, which is statistically significant for each of the 5 factors. The suicide status form is a wonderful form taking into consideration culture and different aspects of culture in our clients. The collaborative nature of the SSF really helps with those cultural considerations. While there are clear-cut questions and answers, it also really helps to open up a discussion with the client, which can really help you understand their cultural situations and implications and things of that nature when filling out the suicide status form and even coming up with a treatment plan for them because of the holistic nature of this assessment. Some of the more specific suggestion from the CAMS website to make sure that that conversation is taking into consideration the culture of the client are to start by asking about physical pain to ease into the psychological pain. A lot of cultures, there's a stigma in discussing suicide and psychological pain, so it helps to start with the physical side of things, such as where on your body do you feel the pain when you feel like hurting yourself. Another option was to recognize internal, external, and systemic or institutional factors of stress, understanding that it can be several factors that play into stress for our clients, and a lot of that does depend on their specific culture. Addressing procedures of disclosure and confidentiality, allowing for questions also really helps the clients be a part of the process, but gives them the freedom to feel uncomfortable and to feel supported in that discomfort, knowing that these things that they're talking about with you are not going to be disclosed to others, and how this information is handled really helps them to establish that rapport and that trust with the therapist. It's also really important to discuss family dynamics, understanding that families in some situations are protective factors, and in other situations they're risk factors. So allowing culture to dictate that, the specific client's culture to dictate that, because it will look different for every client. Again, affirming openness of the clients. Some cultures don't talk about these things because they are taboo, or maybe they look bad for the family. So just affirming the client for their choice to be open and honest with you and talking about something that they may be culturally uncomfortable with. Discussing the concept of being a burden to others, and even delving into how does your culture deal with things like this or discuss the issue of suicide. And then also taking into account the financial stress aspect. For each individual, their financial situation is going to be different. So talking about that stress and how therapy is going to impact that level of stress. Clarifying terminology for the client is really important as well. We don't want to assume that every client knows what we mean when we say psychology, or even what we mean when we say suicide. So helping to define those terms that they have. It's also important to take into the consideration the support systems that the clients might have. Again, some family will be a protective factor, some it will be a risk factor. It's the same with their cultural situation. There's a lot of different relationships at play that could be helpful and could be hurtful for the client. So to understand their cultural position, we need to understand those things. Inquiring about potential barriers to treatment is important because, again, based on your culture, it could be different for each individual. And then finally, the website suggests checking with your client to be informed about cultural emotional expressions. So how one culture experiences sadness might look like anger for a different culture. And so just checking in with your client and saying, hey, I see that there's some emotion going on with you. Can you help me understand that expression? And just, again, really focusing on that collaboration with the client in the assessment and also in the treatment.
Okay, so now we are going to look at the best practices. That includes the ethics involved with working with young adults with suicidal tendencies or behaviors. As we mentioned in the past sections, we have chosen SSF as the best option currently, just with the research backing. Part of the reason we like the SSF is because it is just the first step in a therapeutic framework. So SSF can be utilized individually, but it is also a part of the CAMS management of suicidality. So it's the collaborative assessment and management of suicidality is what CAMS stands for. So the SSF allows therapists to see where the client is currently, but then it can also be the beginning of the stabilization plan, which is called CSP. When we look at the best practices involving utilizing the SSF and its results, we want to look at it in the framework of CAMS, which again is a therapeutic framework. The CAMS is set up to be treatment over a period of time, say 6 to 8 weeks. However, we're going to look just at the first session where the SSF would be administered. One thing to note is that the goal of the SSF is to be a collaboration between client and therapist. So it's not an individual doing a self-report, it's them working together and having a conversation surrounding the questions. As the therapist is working with the client, additionally, they're going to do a further assessment of psychological pain, hopelessness, self-hate, stress, agitation, and the overall behavioral risk of suicide. Once those have been kind of fleshed out, then the therapist is going to help the client identify reasons for living. Typically, the course of treatment with stabilization for a client is to create a suicide contract of what they won't do. They won't kill themselves. This treatment plan is looking at helping the client recognize, again, their reasons for living, but also what they will do that week in between their next treatment versus what they won't do, which would be, I won't kill myself. It is important to note that during this first session, the therapist will also be assessing whether they believe that this course of treatment is applicable for the client. So the goal of CAMS is for it to be an outpatient treatment. However, there may be signs where the therapist decides it is best to put this client in inpatient, and then we will continue this course of treatment once they've been stabilized and inpatient. Continuing on into the conversation of best practices, we're going to look at best practices that surround legal and ethical considerations when working with young adults who are considering suicide. One of the biggest things to note is just simply that there's the potential for a life lost in this situation. And so that in and of itself, as counselors, should encourage us to offer our best care possible. But on top of that, it should be noted that the highest number of malpractice cases presented against therapists and counselors revolve around suicide and suicidality. So that, again, is another reminder that we need to know what we're doing and understand our role and the care that we're giving in these very tricky situations. Another aspect to consider when looking at best practices for legal and ethical consideration is simply to go back to the ACA Code of Ethics. Looking here at the screen, you can see where there are many parts of the Code of Ethics that would apply to working with individuals, specifically young adults, with suicidality or suicide ideation. Just to name a few are the informed consent, the categories regarding respecting clients' rights, treatment modalities, and competence to use and interpret assessment instruments. Informed consent ultimately is looking at letting the client know upfront what treatment you're going to use, and also the limits of confidentiality. Again, that goes into the respecting clients' rights. They need to know that upfront if they communicate that they are going to do harm to themselves, that you have to break the limits of confidentiality or break the confidentiality. Additionally, the other side is treatment modalities and competence to use. And so as a clinician, it is our responsibility to know the ins and outs of the treatments we are using. Specifically in these cases where it may be life and death, it is very, very important for us to know the frameworks that we're using, to know the treatments that we're using, so that we do no harm and potentially help the client move forwards.
So in order to become trained in the suicidal status form under the CAMS, there are two different options that they give us. The one is to just become trained, and the benefits for this is that it treats large populations of suicidal ideators. It's affordable training, it's cost effective and a system of care. It also reduces the risk of malpractice. And then they have found that the clinicians and patients like this CAMS program. And then they have found that it builds the clinicians' confidence with treating suicidal patients. In order to be able to get trained, CAMS trained, it takes up to 12 hours of coursework, which is all available online, and 4 hours of calls when working with the clients. It involves completing 3 different elements. The first element is CAMS Foundational Video Course. This is a training by Dr. Jobs, who is the developer of this training. And he introduces unscripted clinical demonstration of the use of CAMS with patients through the course of 12 sessions of the CAMS framework. You pass a free test or purchase 3 of the credits for an additional $36. But this video course just by itself is $99. The second element is the online role-playing training day. This is designed to enhance the knowledge that you have of CAMS framework, while also providing an opportunity to practice completing the suicidal status form with other mental health professionals, learning the model as well. This cost is $200. The third element is CAMS consultation calls. It's attending 4 consultation calls after you're using the CAMS with patients. The call gives you a forum to discuss cases, best practices, and have your questions answered by an experienced CAMS consultant. And that's $60. Or it's $15 per 1 hour call for individuals. This process totals $359 to become just trained in the CAMS. The other option is to become CAMS certified. And there's several different benefits to this, but the one benefit is if you become CAMS certified in your facility, you can be the designated CAMS provider for that facility, and then you can also be a CAMS approved clinic. And so then you just being certified in this, you're going to be able to train others. You're going to be able to help with the consultation calls and working with others to become trained as well. So, and then it's, again, you're treating suicidal clients, which is stressful, and CAMS can kind of help build confidence and competence within everybody that's working with this in the facility. In order to become certified, there are 2 steps. And the first step is to take and pass the book CEs of Managing Suicidal Risk, 2nd edition, a collaborative approach, which is 6 hours, and the cost is $49. The second step in becoming CAMS certified involves a review of your knowledge and competency within the CAMS framework. And then you will also be required to do a role play session in the initial session. And this is where a CAMS consultant will be playing a scripted client. The review lasts up to 120 minutes, and they recommend that you have used CAMS with at least 3 clients in order to pass the review. And the cost of this is $400, and there is no discounted price to retake a review. So you'll just pay, it's $400 every time you need to take and pass the review. They do recommend that you get recertified every 5 years, which involves going through another review. And then both trained and certified, they require you to participate in various CAMS training courses to be able to stay up to date on the CAMS framework. And all of these assess the program that you become certified or trained is on their website, which I've provided for you above. There are a lot of resources out there for this assessment, and I feel like it's important to include the actual website that you can be trained on. And it gives a lot of resources on that website. It gives you additional educational content. It gives you events that they're holding and webinars to get further training on. And then there are also 3 books that I have listed here. And I feel like those 3 books are an important part of learning more about this assessment, and not only learning about the assessment, but actually working with the assessment as well, and just a lot of great information. Something that I found very interesting in doing the research was coming across the suicide contract. And I feel like this suicide contract is going to become more and more popular in the future. It just is a lot. There's a lot of benefits to it. Weiss tells us in a study that he does that it not only helps the therapist pinpoint different things, but it also helps the client commit to not harming themselves. So I feel like this suicide contract has a lot of benefits by using it within the assessment, and I think that in the future this is going to be something that a lot of people try to utilize with their clients. I also feel like just basically continued research on this assessment is going to be key. We've already heard a lot of the research that throughout the previous slides, and as long as we continue to research and adapt the assessments as changes are needed, I feel like that is going to be a huge part of the future, and constantly adapting those, whether it's the questions on the assessment, and also being trained as a professional to be able to adapt to those changes as well. And then also with the CAMS, I feel like heading towards the future, they are changing the wording to where it's going to be more reasons and goals to live. So they're going to change, like they're changing the focus and trying to give clients an opportunity to give us reasons for them to stay alive, and set up goals to live, and just kind of build that hope for the client again.